Hello again. So today we've got the Managing Initial Assessment lecture. So far you've done 3 lectures with a bit of luck, specifically on initial assessment. And those of you who've never done it before will hopefully have done some of the suggested additional webinars that we thought would be helpful to inform the whole concept for you. Today I'm joined by Judith Morgan, who's our Director of Competency and Quality Assurance. And that's important because Judith's going to explain to us how the faculty has provided assessment tools and how that all works towards assuring that you can do initial assessment well. So, usual stuff to kick off with. If my slides will move on. There we are. Of course, we're recording the session and we will make it available for those who've registered for our education bundle. Stay on mute unless you're speaking, because it always causes interruptions at our end, or echoes if you do that. If you want to speak, just hold your space bar down to come off mute. Use the chat function if you wish to ask any questions. Judith's across that, and we will answer all questions or follow up later depending on what's appropriate. And please do not share our codes unless you've been given our explicit permission to do so. So before you get started on this lecture, it's really important that you understand it is the 4th of a series, and you really need to watch the other 3 first in the order on the screen. So you need to watch an introduction to initial assessment with myself and Nathan Griffiths, then do the primary assessment webinar, and then the secondary assessment webinar. And then once you've done that, and only once you've done that, are you ready to talk about managing initial assessment? So let's have a look first at what the acuity model of initial assessment is designed to do. Remember, there have been a variety of different ways that we can assess our patients that have been used throughout the history of healthcare, but obviously in this particular context in relation to emergency nursing. Initial assessment is a nursing task, but it's really important for all sorts of reasons that it's a consistent process. So the whole point of NHS England having produced an acuity model in wide consultation with a great variety of professionals working in emergency care is that it is consistent. So it doesn't matter whether I turn up at the far north of England, at the far south of England, at the extreme east, the extreme west, or anywhere in between. Doesn't matter which department it is. If I go in with the same presenting condition, I should be given the same acuity level. The whole point of the exercise is that it will reliably pull out patients who are most urgent with either life, limb, or sight-threatening conditions. That it will pull out, and they get a 1, the patients at risk of deteriorating if their condition is not treated urgently. So that comes in at acuity 2, and that could be patients within ED or it might be outside ED. That we will pull out the patients with a low level of risk who could be assisted to use digital triage, or could, if you've got it available, or could safely wait for secondary assessment. And those patients whose needs might be better served outside an emergency department. So that's potential redirection. I'm not going to talk about redirection today. I said in the first video, we wouldn't talk about redirection. It's a whole other skill set. So let's just focus on that consistent process that means we're pulling out the sickest and the ones that can wait. Oops. Let's go back one there. So here's the model. Reminder, it's a 2-step process. So primary assessment does what it says on the tin. It's the primary one, and this is pulling out the sickest. Now, looking at the figures that the NHSE team have been able to assemble, approximately 10% of your workload will be acuity 1 and 2. So that means for every 10 patients that walk through the door, only one of them will be an acuity 1 or an acuity 2. And so on and so forth all the way through the day. So if you turn over 400 patients in a day, 40 of them will fall into acuity 1 or 2. The see later group, the acuity 5, that's the low risk. We could potentially redirect them to somewhere else, or we could very easily have them sit and wait in the waiting room. That, depending on your exact demographics in the area that you serve, could be between 20 and 40% of your workload. So again, let's look at how many of the patients that is. That means that for every 10 patients, 2, 3, or 4 of them will fall into acuity 5. So within primary assessment, in theory, you have taken half of the patients and moved them on in one way or another. So you've either sent them straight into resus or majors because they need that level of attention at acuity 1 or 2, or you've said, you know what, good to wait, go use the digital triage, or good to wait, go down to the UTC, whatever that is. And the other 50%, or potentially up to 70% of the patients, so between 5 and 7 of the remaining every 10 patients, will go to secondary assessment, where we're going to do the measurements and the pain and all the rest of it. Okay, so for every 10 patients, 1 gets an acuity 1 or 2, 2 to 4 are going to get acuity 5, and 5 to 7 will go to secondary assessment. So you can see already that should mean that people speed through that initial assessment process. So primary assessment, what is that about? The key question is, how sick is your patient? How sick is your patient? Not, do they need to pick up the kids from school? Not, they're your mate from down the road, but how sick is this person? And what you're required to do is decide what the chief complaint is. That's usually quite straightforward. Chest pain, abdomen pain, painful leg. Note the frequency of the word pain as I go through that. What discriminators you've used. And that's easy because you look at the tool, and we showed you that in detail on the primary assessment lecture. We went through and looked at the red flags and what would make a patient knock up the acuities. Your decision on the acuity level, and then the patient destination. So that might be acuity level 1, resus, acuity level 2, high dependency area of majors, acuity 3, waiting room, acuity 4, waiting room, acuity 5, UTC. So we just have to pull out the most sick and the lowest risk and send the rest for more measurements. It's all that's required. Let's have a look at secondary assessment. What are we doing there? Again, clear question. How sick is your patient? And the job of secondary assessment, as you'll remember from our lecture on that, is to do all the measurements, do the obs properly, get a full set, make sure you know how frequently you want them done, give any medication that you may wish to give, adjust the acuity score. It's okay to say that primary assessment thought 3 or 4, and that's why they sent to secondary assessment. But actually, having done the full set of obs, you want to up it to a 2. That's okay. And obviously document everything. So making that a little bit more granular, we're expecting you to record the observations. So clearly in a secondary assessment, you need to have your secondary assessment room set up to enable the recording of observations. And that's not just pulse and temperature and SATs. There would also be visual acuity as well. You need to have somewhere that an ECG can be done. That doesn't mean the patient gets to lie down and have their ECG and occupy that space the whole time. What we've seen in the pilot sites and the early adopters is that people are setting aside an ECG room where you might do an ECG, or you might do ECG and bloods, whatever's appropriate, and you might have an HCA or a technician, depending on what you call that role, doing that job at the request of the secondary assessment nurse.
Jeanette, can I come in
Of
there?
course you may.
Just, um, you said about that you can up the acuity up to a
Yes,
priority or an acuity one or an acuity two. Equally, if you find that the vital signs don't show anything that bad,
you
then
could
there's
bring
no
it down.
reason why you couldn't put the acuity down as a 5. It just means that they're safe to wait.
Yes, which is always reassuring.
Yeah.
Makes everybody's blood pressure go down when we know the patients are
Mm.
safe waiting. Um,
Yes.
the other important jobs in secondary assessment is that's where you give the analgesia. Okay,
Mm.
I stressed how many times I said the word pain as the chief complaint. So it's likely that patients will need analgesia, but that's where you give the analgesia under whatever PGD or prescribing protocol, depending on how your unit works. You also need to give any time critical medication. So if you do have a patient who needs their Parkinson's medication or needs their insulin or needs some other medication that can't wait until the next stage of the whole process, then that would be the time to give it. And that's the place to monitor it. So the
Mm.
secondary assessor is the one
Mm.
across those things, and then any necessary first aid measures. So
Mm.
time to get a wound, a quick wash and clean up
Mm.
and a bandage on. Time to say, right, this is where your leg needs to be held up
Mm.
or your arm needs to be up in a sling or whatever. All right.
Interestingly enough, you mentioned the Parkinson's medication.
Mm,
I saw on LinkedIn today a post that said that a patient had been failed because he had not been given his Parkinson's medication at the right
mm,
time. And so there was a case brought against the health board. So the point you make about noting time critical medication is absolutely vital to the safe care and management of patients within our services.
mm, mm. Thank you. It's always good to note these things because there's so many small actions we can take that will prevent something worse happening. The worst thing that could happen for all of us is that a patient seriously deteriorates or dies in our waiting rooms. That's it. It's the thing that no patient wants. It's the thing that no relative wants. It's actually the thing that none of us want. And I can assure you it's the thing that your chief executive doesn't want as well. So um, those small actions that will prevent something getting worse are absolutely critical. It may not feel
Mm.
like you're doing much. It may feel sometimes like, really, I can't be bothered with this. You need to be bothered with it because it's a bigger mess later if you don't deal with it at the time. Right. So that's all fine and dandy. But those of you with a bit more experience will be thinking, just a minute, how on earth am I going to make this work? Because we've had our triage method set up, we've got the whole geography of the department, the IT all set up, and how am I going to make this work? So the first thing I'm going to say to you is you need to know the wording of the associated risk on your organisation's risk register. Now, many of you listening to me will not have a clue what I just said there. You will have recognised every single word, but it will have made no sense to you. So, from an organisational governance point of view, that means what are your standards, who oversees you, who scrutinises your work. You have to have a risk register in every organisation. That's where you put those things that are bothering people, that are, this is not safe. So let's use a non-clinical example because it's less emotional. What about if you have some automatic doors that keep opening and shutting and opening and shutting and opening and shutting? Well, that's just really irritating. It also means the heat gets out. It also means that the patient's dignity and privacy might be compromised, those sorts of things. So you have some malfunctioning doors. What do you do about that? Well, you report it on Datex, or other incident reporting systems are available, but it happens more than once or in more than one area. And then somebody in more senior management says, I think we might have an organizational risk here. And what they do is on another part of your incident reporting system will be a risk register. And what you do is you write up a risk that says, this is what is happening. This is the risk. If we don't do something about it, then either there's a patient safety risk, or there's a patient experience risk, or there's a reputational risk, or there's a statutory risk, or there's a financial risk. So depending what the issue is, there could be all sorts of things on there. There's then a risk scoring matrix, which is probability against severity. And clearly, the most severe is 5. It's always on a 1 to 5 scale. So it will be 5 times 5, which is 25. So that is the highest level risk score you can get. Now, I assure you that the highest risk on every organisation's risk register is processing of patients through initial assessment in the emergency department. I absolutely guarantee that that is the thing that upsets the whole organisation most. And the reason for that is because you don't know what you don't know. So having a load of patients sitting in a waiting room with a whole group of presenting conditions, the severity of which is not known, is a huge risk. And you only have to read up the cases of people having difficulties in waiting rooms and ending up dead, and the consequent coroner's cases and what have you, to understand how high risk that is. It's a patient safety risk. It's also a huge reputational risk. So your organisation will have that risk on the risk register. And those of you who are more senior need to find out what that wording is. Your matron or your head of nursing should be able to tell you what that is. If you're going to change over to initial assessment, you will need organisational buy-in. There is no good thinking that you can do this on your own. You can't. It needs to be an organisational level change project. And to do that, you need the governance body of emergency and unscheduled care in your organisation, often called the Emergency Care Board or something like that. You need them to be driving this change. They must be convinced that the NHSC model of initial assessment will work better for their organisation than whatever they're doing currently. Without their willingness to do that as a big change project, it will not be possible to achieve this. You need the seniors on board. You also could do with project management support, and that only comes by having organisational buy-in. The next thing you need is IT compatibility. Now, we've all got different IT systems, and I guarantee you that changing the way you do that initial assessment will cause problems if your IT can't support the change. There are always challenges with IT, and what tends to happen is that when you adopt a new IT system, it gets what's called a local configuration to how you do things here. And that doesn't just snap change when you change the way you want to do something. So you will have IT compatibility issues. So there will, hence the risk register and the organizational buy-in issue, because this will need project management support and IT support to reconfigure your IT system to enable you to document what needs to be documented. And it will be different. Some IT systems are really easy to swap, others are not. And I will not name names because that's not fair on any of the suppliers. You'll also need a bit of a reconfiguration of nursing deployments on each shift. Now, different places will do this in different ways, but what you need to factor in is that the nursing staff are going to be working in the waiting room and facing the waiting room. So your primary assessor needs to be placed quite near the door. Now, depending on the size of your department, you might decide to have two primary assessors, one for the ambulance entrance and one for the walk-in entrance. Or you might go, do you know what, let's not make our life difficult. Let's just start with a primary assessor on the walk-in side of things. And that primary assessor will need to be close to the door and facing the door so that they see patients as they're coming in, but with an easy view of the waiting room. And that primary assessor will need a receptionist near them so that the patients can give their name and details quickly, and the primary assessor can either pull the patient in to speak to them first and then pass them on to reception, or vice versa, that reception can take very basic details, issue a wristband, and then straight to primary assessment. So that will take a little bit of working out locally, because everybody has a slightly different layout to their waiting room and reception. It doesn't mean you have to have the builders in, because you might need to play around a little bit with your available spaces and see what works in your space that you've already got before you worry about the builders. You'll also need to have a think about what hours of provisions on the alternatives to ED there are. So many of you will have an SDEC, same day emergency care unit. Some of those will be run by acute medicine. Some of them may be run by emergency medicine. You may have a surgical assessment unit of some type as well. If you have peds on site, the chances are you've got a pediatric assessment unit. Some of you may be lucky enough to have an eye casualty. Quaint old term there, but they still seem to call them eye casualties. Some of you might have an urgent treatment centre, a UTC, and all sorts of other variety of things. Maternity triage springs to mind, which is kind of a maternity ED type facility, sort of bolted onto most delivery suites. You might also have a gynae assessment unit, something like that. So you need to be really clear on what hours those all operate and when they take the last patient, because you can't be sending a patient off to one of those areas to be seen after they're finished or after they've reached their maximum number of patients. So there's a bit of work to be done with the people running those services about how would you feel if, and how are we going to get that captured on the IT and then passed over so it gets picked up on the IT in SDEC, because we don't want to lose the patient down a cyber rabbit hole. And you'll also need to work through agreements with what patient presentations would they be happy to have and what do they need done before. I mean, for example, let's just say for the sake of argument, somebody comes in, stinking headache, and you're thinking, could be a variety of things, but actually what this patient really needs is an acute medic. Okay, I could send them to SDEC, but the CT scanner's on the ground floor and the SDEC's on the first floor. So I'd be a bit mad to send the patient to the SDEC just to come back to the ground floor. So tell you what, we'll send them to CT first, and then post CT, hang on a minute, because if the CT shows something unpleasant, I maybe don't want to send them to STEC, so I maybe want the A&E staff to get to review the CT scan and then move to STEC. So there's all sorts of special cases where you need to just have those conversations in advance, plan ahead, work out what you are going to do if for each of those assessment areas, because they will all have a little bit of flexibility, but also a little bit of limitation on what they can take and when. And of course, it makes complete sense for investigations to be done beforehand. So it may be that your agreement is that's fine, we don't mind taking them, but please can you make sure that this set of bloods and this type of X-ray are always done en route up and out. So those sort of things need working through in advance. You can't do it on the hoof, because I guarantee if you do it on the hoof, you'll end up in a pickle, and a lot of people will come to harm. Right, that's great, Jeanette. But what about? So you've got lots of questions now going, oh yeah. But you've given me all those examples. You've given all those examples that we went through, adults and children in both primary and secondary. Fabulous. But hang on a minute, what about clinical red flags? Right. So the clinical red flags are covered by the work we did in the primary assessment lecture. And actually, any clinical red flag you can think of will be picked up in the acuity. So the examples that we were given in a frequently asked questions was but in preparing for this lecture was, what about a high risk mechanism of injury? Well, anyone with a high risk mechanism of injury will trigger acuity too. So that's fine. What about patients with management plans or support plans, depending on what you call them? Well, follow the plan. It's really easy. Read the plan, follow the plan. I have learnt over the years that I've been working with those that actually it's a darn sight easier to see a patient with a plan than a patient without a plan. So just read the plan and follow the plan. And the plan might say, please, can you turn them around and ask them, just ask them question A, B, and C and say, if that's all right, it's fine, you can go home. Or it might say, please direct straight to, in which case do that. Or it might say, please process as normal, but have them wait in a more private area. So do that. Do whatever it says on the plan. The plans should be, just a side issue here, reviewed and updated by the authors with the initial assessment process in mind. But that can be quite a big job. If I just think about my own organisation, we've probably got 600 plus patients on a plan. I wouldn't want to wish reviewing all those on anyone. But as the plans come due, as you switch your system over, you just need to say to the plan authors, okay, your plan's due for review in the next 3 months. Can I just explain to you how the initial assessment process is now working rather than the prior triage process? And can you just slightly reword your plan to factor that in? Should be fine. The third example we were asked about was reattenders with the same complaint. Well, you apply the same model, but you do yourself a huge favour if you read the previous attendance notes before you make a decision. And in some organisations, there will be a requirement that any reattenders with the same complaint see a more senior doctor. That doesn't mean they get a higher acuity. It just means that when it gets to the point post initial assessment that the doctors are picking up the patients, that patient gets a more senior doctor. Okay, what about social issues and safeguarding, we were asked. Right, well, the first thing I would say is consistently complete your safeguarding risk assessments for both adults and children. I've watched in more than one organisation, and that is not well done. It's better done for children than for adults. I'm just going to say there are more adult patients than there are children patients. I know the children are smaller and less able to speak for themselves in many instances, but actually you just need to get over yourselves and consistently complete those risk assessments. I do understand it's a bit frustrating at times. Just do it and follow the advice on the risk assessment matrices. Most risk assessments have oh, if you've come to this score, now do this on the matrix. So just do it and follow whatever the advice is. We were asked about people with a cognitive impairment. Well, again, just apply the tool, but you need to make some reasonable adjustments. So that's a phrase from the Equality Act that simply means that you make some adjustments to reduce health inequalities or social inequalities, but mostly in our context, health. So someone with a cognitive impairment who you've clocked, because some of them are very good and very convincing and you don't know there's an impairment, but where you've clocked that there's an impairment, just make sure they are accompanied to their next destination. Ask an HCA to escort them to the waiting room, escort them to secondary assessment, escort them to have an ECG, escort them into majors, whatever, and make sure the relatives or carers are contacted. And if there's relatives or carers with them, make sure they're briefed with what to expect as the next step and what to do if the person with a cognitive impairment needs further assistance or deteriorates. We were asked what to do about neurodiverse patients. Well, I'm going to be boring on this one. Apply the acuity tool. But you will need to minimize additional stimulation. People who are neurodiverse and indeed people with learning disabilities generally can't cope with large crowds. They can't cope with surprises very well. They can't cope with loud noises. So if you can just minimize additional stimulation, and that might be as simple as keep their back to the rest of the waiting room so that they face a wall or face looking out of a window or something. That will help. Some departments have kits for neurodiverse patients, so ear defenders or dark glasses and that sort of thing that comes in a bag that's single patient use, and obviously the patient then has it for future visits. But you also need to think about using much simpler sentences. So we're all rather guilty of doing compound questions and compound sentences. We put too many clauses in. You need to make your sentences shorter and just ask one question at a time. So not, where does it hurt? Can you point to it? Does it hurt more if I press here? Does it hurt more if I press there? And have you taken any painkillers? It's, can you show me where it hurts? Now, I waited 6 seconds there. I bet it felt like a lifetime to you, and you're thinking, hang on, has my sound gone? You ask one question, you wait 6 seconds for them to just assemble their answer, compose it, and get it out of their mouths. 6 seconds. All right, so less stimulation, keep everything simpler, keep it more direct. And if there is a plan, some sort of support plan, follow the plan. Then what about non-English speakers? Well, we run some very serious risks with non-English speakers, because if we don't know what is exactly going on and they haven't understood us and we haven't understood them, the opportunities to get their acuity wrong are quite enormous. So apply the tool, but can I say it's really important you only use contracted translators. Do not use family and friends. Firstly, family and friends may not be familiar with medical jargon. And so when you use a word that you would normally use quite happily, they may not understand it. Secondly, they may not know that word in the language that your patient speaks. Thirdly, the patient might not actually want a family member to know all the intimate details that will come out in an assessment. Fourthly, you are overlooking a massive possibility for abuse or exploitation going on. And so if you only use contracted translators, then you won't have a problem. All our organisations now have to provide some form of over the phone translation. So I'm not expecting you to get a face-to-face translator for some obscure dialect in the middle of the night, but you should be able to get a telephone translator, because the translators for these services do live all sorts of places in the world, so they will be in a time zone that's awake. If you're unsure, increase the acuity score, because it's safer to assume they're more serious than they are than less serious. It's probably also correct when you actually get to the bottom of it. But those of us in human healthcare are really not as good as vets at working out what's going on, so let's not pretend we are. Okay, what about risks to staff? Okay, let's have a look at that then. So we were asked about drug or alcohol consumption and violence and aggression. So we've put up here the acuity tool section on mental health, and you can see this is from the secondary assessment matrix, and you can see there that high risk, medium risk, low risk of aggression and violence. So that's straightforward. That will give you where you need to allocate them. And these come under, the high risk comes under acuity 2, the medium under 3, and the low risk under 4. Drugs and alcohol affect the airway. So with drugs and alcohol consumption, what you're looking for is clinical red flags. And if you, in addition, get aggression and or violence, then you apply that mental health matrix to it. And it is as simple as it reads. It's nothing more complicated than that. Next thing we were asked about, what about infection risks? So there's two infection risks. There's the donor, that's the person who's got the infection already and would like to helpfully share it with all of us. So that would be the people who were delighted to come back to Britain when they were trapped wherever that had COVID. And of course, several of them brought it back, which was the reason that we had quarantine, which I'm sure was a delightful experience. Not. So a returning traveller is the obvious one. TB, if someone's got TB, we don't really want them coughing over anybody else. Thanks very much. Or it might be that they've been exposed to communicable disease of some other type. You've got infection control guidelines for that, so follow them. That doesn't mean the acuity level has to be followed, has to be changed necessarily. Apply the tool and decide on the acuity level. How sick is your patient? But if this is a returning traveller with a very high temperature, you probably don't want them giving it whatever it is to the whole waiting room. So isolate them in whatever way your infection control isolation guidance has been written. The second party in an infection risk is the recipient. That's the person who would more easily catch an infection. And we need perhaps to put them into protective isolation, good old-fashioned barrier nursing, reverse barrier nursing even. So that would be the transplant patient who's on immunosuppressant drugs. That would be the chemotherapy patient who has had their white cells wiped out by their chemotherapy. Anyone else who's immunosuppressed, because there are some fabulously weird, wonderful rheumatological conditions where immunosuppressants are used a lot. And anyone who's ever had their spleen removed for potentially very good reasons, but regardless, that makes them more at risk of infection. And so apply the acuity tool and then apply your infection control guidelines. Okay. Let's just take 5 because that's quite a bit there. Okay. So now let's have a think about specific patients, because there are specific patients to think about. And a lot of this depends on your local configurations. So, pregnancy. Now, pregnancy is a specific factor within the matrix and within the clinical red flags that says pregnant and, essentially, because pregnancy isn't an illness, but we don't want people to be unwell in their pregnancy and that not be managed. So, first things first, how pregnant is your patient? Because early pregnancy assessment will usually take people who have a pregnancy of less than 20 weeks. Why is that important? Because a pregnancy of less than 20 weeks is not going to survive birth. So that's it would be a non-viable fetus if it was born, or delivered, whichever way you like to look at it. So you may find you have either a gynae assessment unit or an early pregnancy assessment unit, and they will have a protocol for anyone less than 20 weeks pregnant. The midwives kick in very firmly at 20 weeks. So my organisation has what they call maternity triage. And essentially what that is kind of, I suppose, a maternity assessment unit, but it's right next to the central delivery suite. And so the idea is that women present to the maternity triage. Think of it as like a maternity A&E. They present there, they get assessed there, and then if they're in established labour, they move into the delivery suite. If they're not in established labour and could go home or could go for a walk around the hospital or are having some complication, then that can be addressed in that area. And in maternity units, they will generally have some sort of assessment area so that the obstetricians can move between the assessment area and the delivery suite, and you kind of keep the doctors flowing as well as the midwives. So make friends with your midwives, work out how that all works, make friends with your gynae nurses, and just get a feel for how, what time of the units are. Maternity triage tends to be a 24-hour day operation, whereas early pregnancy assessment tends not to be. And so you just need to be aware of where your limitations are. But it's entirely possible that you could redivert a pregnant lady off to one of these services very comfortably, who'll be very happy to have her and do any scanning and what have you. And, yes, she's presented at the emergency department entrance, and that's fine. Finding your way around some hospital campuses is not easy if it's one you don't know and you haven't planned the route in advance and all that sort of thing. So just bear that in mind. It's a lot easier to do that. If you haven't got maternity on site, and I've worked with both maternity on site and off site, and I have to say it's much nicer having maternity on site. If you haven't got maternity on site, well, then you need to work out what's feasible at what hours of the day. And what can be achieved, or whether you ask the doctor to come to the department. But anyway, at initial assessment, you may well be able to divert these patients off to either gynae or maternity. Now, some people will say, right, what about mental health specific pathway? Well, there's lots of different ways of doing this. In my organisation, we have a co-streaming model, which means that mental health nurses work in the initial assessment areas alongside the A&E nurses, and they simply pick up the patients that come with a mental health presentation and see them. So instead of them seeing someone in initial assessment and then being passed to the mental health nurse, our mental health nurses just pick those people out of the queue as they arrive. And see them straight away. That means the patient gets seen by a mental health specialist straight away. Hurrah. It means that mental health nurse can have more time with the patient. Again, hurrah. And potentially they can turn them around reasonably quickly from the emergency department and they don't need to be admitted. Again, hurrah. So that works nicely. You might have a mental health liaison team. We're supposed to have one in every health organisation in England. So it depends how your mental health liaison team works. They may only see patients on the ward. They may come down to the emergency department. So whatever works there, whatever your normal method is, it would be good to flag any patient coming through initial assessment with a mental health presentation to mental health liaison at your earliest opportunity. Now, some areas have a mental health liaison team kind of 8 a.m. to 8 p.m., but outside those hours, they use the crisis team. Now, the crisis team is what it says on the tin, but usually those are teams that are set up to provide 24-hour-a-day mental health intervention within a county or a part of a county, depending on how many, what your density of population is and how many different trusts are providing services. The problem with that, just to give you some clear context, is that might mean that your crisis team overnight is 3 people, and they are covering a whole county. And if they have to go out to a patient, which does happen, they go out to the patient's own home, they would then be unavailable to the emergency department at all. It's going to cause a problem. So just factor that in. Might be a good reason why you'd like to put in a business case for a 24-hour-a-day mental health liaison team. But, who am I to tell you? Next problem is the Section 136 patients. So for those of you not familiar, Section 136 is of the Mental Health Act, and it is a power used only by police. And they, instead of arresting a patient, they detain them under Section 136 of the Mental Health Act and convey them to a place of safety for psychiatric assessment because they were threatening harm to themselves or to others in a public place. That's really important. Those last 4 words, in a public place. Section 136 can't be put on in a patient's home. Just as a quick diversion, the police can put on Section 135, but that's very unusual. Normally, it's better to get a psychiatric team to come out to a patient's house and do a formal assessment then and there. And the police tend to reserve themselves for Section 136 in public areas. Now, for those of you who are thinking, hang on a minute, this is a bit of an issue, we don't have them or we do have them. Every area has come to a slightly different configuration on what is acceptable and what is considered a place of safety. Depending on how far away your emergency department is from your psychiatric hospital, and in some places it's on campus, hurrah, in other places it's well away, you might find that there is a local agreement that the police take all Section 136 patients directly to the 136 suite at the psychiatric hospital, where, strangely enough, there are psychiatrists already on the premises and can do the assessment. Or your emergency department might be considered the place of safety to which the psychiatrists come. Tricky business, this. So you'll need to just factor that in. But if police arrive with a patient under a Section 136, you need a process within your department for how you're going to manage that patient through. Be clear, the police cannot leave the patient on a 136 because only a psychiatrist can take that section off. The rest of us can't. However, you may have heard of the Right Care, Right Person initiative, and that comes in 4 phases. The 4th phase of which is a renegotiation, essentially, of your multi-agency Section 136 policy so that the police are not kept with a patient for 24, 48 hours until physical health care has been concluded prior to psychiatric assessment. So be aware that there's lots of politics and there's lots of logistics around how we manage patients on a Section 136. You may also have some patients who are planned to be detained under the Mental Health Act who arrive at an emergency department door. Now, on the whole, working in an acute hospital, you will find that those are eating disorder patients who need to be detained for refeeding, and your liaison psychiatrist will come and do the detention. Now, you cannot detain someone under the Mental Health Act to an emergency department. They have to be detained to a bed on a named ward. That's what the law says. But it may be that the Community Eating Disorder Service are so concerned about the physical health of this person that they would like them put through the emergency department processes of initial assessment and bloods and x-rays and whatever to determine how acutely unwell this person is and have a physical healthcare plan crafted before the detention happens. So in those cases, treat those patients as really sick. Eating disorder patients who need to be brought into an acute hospital for refeeding are sick people. They're not, whatever they say to you, they are sick people because we don't use hospital beds if some treatment can be used, it can be done in the community. Now, the next two bullet points are about patients who can wander off. So when I'm thinking about managing mental health patients, there are a couple of things that are really risky. The first is that they leave before being seen. Now, I've recently taken up having a report sent to me every morning at 8 o'clock detailing which mental health patients left before they were seen. I'm delighted to see that it's usually a nil report. And part of that, I suspect, is because in my organisation we have co-streaming. So there's a mental health nurse available to the emergency department 24 hours a day to see patients. And so they do actually get seen relatively quickly. And when I say relatively, I mean within an hour. So often they haven't got to the point of getting restive enough to leave before being seen. But those are a very risky group of people. And so if you're seeing a mental health presentation through initial assessment, please bear in mind that at some point you will need to document a very brief description of the patient, height, hair color, clothing description, so that if they do leave before they're seen, you've got some idea who you're looking for, because they may not have got any further than the toilets. And you've also got their phone number so that you can phone them, because some people can't manage to sit in a crowded room, but are actually quite happy to stay on the site. They just need to pace up and down a bit and would happily come back to be seen when called. And then you've got to factor in that some of those patients may also abscond. So they're going through your processes, but they may abscond. So again, that preventative matter at initial assessment, definitely at secondary assessment stage, that you've got a description of the person captured and you've definitely got their phone number. Saves a lot of later trouble. Okay, suspected safeguarding concern. Now we've partly tackled this. In that I have said you must just consistently complete your safeguarding risk assessments. It doesn't take long. The initial assessment bit of a safeguarding risk assessment can be an eyeball only. You don't have to ask terribly complicated questions, but please be very aware of the signs of neglect. You don't have to open a paper or open your news feed for many days in the week before you hear about underweight children or underweight people with disabilities or people in soiled and stained clothing. You don't need to be around an emergency department for even a week to find people coming in with self-neglect. Typically, they would be coming in through your ambulance entrance because the likelihood is that they've come that way, but just be very alert to signs of self-neglect. Always have that question in your mind when you're given a history about how an injury happened. Is it possible that this injury was caused this way? Now, you're not going to be the final arbiter of that, but just, if that question flashes across your mind and just for a second you go, nah, then increase the acuity so that that can be explored at greater length, and you will find that is in the matrix for the acuity tool. Be alert to potential exploitation. Don't use the accompanying people to translate. Be alert for signs of domestic abuse. It is often just the worst of the worst of the worst that pitches up. But just again, is it possible that this person got this injury the way they've said? Often the answer is no. And knife wounds, just a caution on knife wounds. You will know that you have to report all knife wounds to the police under separate legislation, but beware the person who says they've stabbed themselves with a knife. The usual pattern of self-harm wounds caused by a razor blade or possibly a knife is one thing, but someone saying they stabbed themselves with a knife is another. Experience suggests that self-inflicted knife wounds are actually the result of somebody defending themselves against an attack by stabbing their attacker, and it may be that you've got the attacker with you. But anyway, they've got a knife wound, so you're going to have to ring the police, and you'll need to just have a think about who's going to do that. But initial assessment doesn't seem an unreasonable place, certainly primary assessment, but have a think about it. Decide what works in your unit. Suspected sexual assault. Now, this really does need keeping across because you can get this very wrong without trying. And if you get it very wrong, then you mess up somebody's court case. So the drill goes, prioritize urgent medical needs. How sick is your patient? Follow the acuity tool. Remember that whatever you do, whether that be in primary assessment when you're trying to be kind and comforting, or whether you're in secondary assessment where you're maybe trying to apply first aid, that you may need to preserve evidence. Blood that's coming off the patient may not be theirs. It could be somebody else's mixed in as well. So that's potentially forensic evidence. So don't throw away all your gauze swabs. We shouldn't be initiating any forensic examination ourselves in emergency care because we're not trained to do it. But have you got a standard operating procedure with your local SARC? That stands for Sexual Assault and Rape Centre. If not, there's another part of your project. Get someone down to the SARC, initiate a conversation, make friends, work out who's going to do which bit when. Because actually, if you set up an agreement between your emergency department and your SARC, you can have quite a lot of really free-flowing information. They're often not run by the same organisation, so that's problems that you'll have about can I share information or can I not? Yes, you can, but carefully. And we don't want the SARC trying to bypass A&E, and likewise, we don't want A&E not factoring in the expertise of the SARC. So actually go and make friends, work it out, and just sort out a protocol between you of how you're going to work collaboratively together if someone tips up in an emergency department saying they've been sexually assaulted, or if someone who's been sexually assaulted tips up at the SARG and has medical needs that need to be addressed. And don't let me forget to mention the non-fatal strangulation guidelines. You should all be following them. If you don't know about them, you need to have a look at them. They're on the website of the Faculty of Forensic and Legal Medicine. They are fabulous clinical guidelines. Actually, they're relatively straightforward to implement. And what should be happening is that anyone who discloses or says yes when asked, discloses any non-fatal strangulation, any choking, any attempts at suffocation, any attempts at drowning, they need to go for CT with contrast within an hour, and they need therefore to be prioritised to facilitate that. So you just need to work out within your department, have that conversation with the emergency department consultants and with radiology to work it all through. I have to say we've found that extremely straightforward in our organisation. We've just said, here's the clinical guidelines. They go, oh yeah, we can do that. Radiology, here's the clinical guidelines. Oh yeah, that makes sense. Right, are we going to have an argument with each other? No, we're not. Great, hurrah. Thanks very much. Everyone's following the guidelines. Just do it. And they have just done it. So we haven't had any difficulties. I am aware that other organisations have, and have found all sorts of back routes and workarounds, which aren't necessarily the most helpful way of doing things. The best place for everyone who has had any non-fatal strangulation in whatever format is the emergency department, because actually emergency department through to CT with contrast is a really easy pathway. It's one that is well used every day, and it's all healthcare professionals who are used to working at speed for acuity and looking for these sort of issues. So primary assessment, absolutely, but you might just need to be going, oh, hang on. If we're going to be following non-fatal strangulation guidelines, could the primary assessor possibly just send straight for? Or do you want the secondary assessor to send for? Or do you want to put that acuity up to achieve? So just work that through yourselves so that your patient gets through in the time required. You may put them at acuity 3, but have an agreement to send for investigation, which would enable that to all happen within the time frame. Now, you can't work in an emergency department for very long before you have patients brought in by the police. I'm going to get boring again. Apply the acuity tool and allocate the right acuity level for the patient's presenting problem. But you will need to put the police and the patient somewhere more private to wait. You can't have them sitting in the main waiting room. People under arrest have much higher levels of adrenaline. They've been running away from the police or whatever, trying to get away. And their adrenaline levels are up and they're in full fight or flight mode. So if we give them an audience or we make them feel in any way potentially at risk or threatened, they will try that flight or fight and they'll go. So let's take them away from the audience, put them somewhere where everyone else doesn't gawp at them and where they don't get that feeling that they're going to need to try and break away. Don't expect the patient's handcuffs to be removed or the police to leave. So you might need to just choose your language a little more carefully. And bear in mind that although you'd really like to have the conversation with the patient on their own, you can't do that when they're under arrest. You have to, whatever you have to say, you'll have to say in front of the police. What about patients in prison custody? Well, convicted prisoners, much easier kettle of fish because the adrenaline levels are much lower. So that's easier on the whole. Every prison has a healthcare facility. So on the whole, those healthcare facilities will manage most incidental issues. So it might just be that they haven't got the full setup on site overnight or at weekends. They're not too keen on sparing 2 prison guards to come to hospital, so they will prefer not to do that if they can possibly find another way to do it. Again, correct acuity for the presenting problem. How sick is this patient? Again, just put them somewhere where people can't gawp at them. It's not necessary. It just causes unnecessary problems. And you can't expect handcuffs, chains, or prison guards to go anywhere, so you're going to have to work around them. So just have that thought. We've done primary assessment. Now, where are they going to go? Where are they going to wait? That to me feels more of a logistics issue than an acuity issue. But of course, that's part of managing the entirety of the initial assessment process. Which brings us on to VIPs and celebrities. Now, every area has their own celebrities. Everybody has some resident folks. That might be sports people. It might be show business people. It might be some of each, depending on how unlucky you are. You may have royalty, depending on exactly which area of the country you are. Some areas have royal residences, others don't. Usually, emergency departments with royal residences nearby will have a plan that is tested every year to make sure that if a member of the royal household needs no, a member of the royal family, because it's not the household that's the issue. It's the royal family themselves. If a royal family member needs healthcare in an emergency, there is usually a plan in place that has to be rehearsed and everything has to be checked. And if that's the case, follow the plan. Just do what's being rehearsed. For anyone other than royals, you just go with the correct acuity for the presenting condition. But gone are the days when I would have said they can wait in the waiting room like anybody else, because everyone's got a smartphone. They've got it out and they're all sending off the photo to their mate or to the papers. So we've got to be, and consequently, VIPs and celebrities are somewhat twitchy about their privacy and their confidentiality, because they're entitled to confidentiality just like anyone else. So you're going to have again logistics, a more private area. It might get a bit full if you have the police in with a prisoner, prison guards in with a prisoner, and you've got a VIP in, but there's no reason it couldn't in theory be the same space. Just remember, don't do the fan bit. It's not edifying. So no photographs, no autographs. They are a patient. How sick are they? And occasionally some of them will have a security detail. So have a bit of a plan about how you're going to manage the security detail, because some bodyguards are absolutely not allowed to leave their principal, but their principal's entitled to confidentiality as well. So just needs a bit of careful thought about how that's going to be managed through that initial bit so that the patient is not exposed to their privacy and confidentiality being breached just because of what they do. And then, of course, there's always our own colleagues. So again, a bit boring here, allocate the correct acuity for their presenting condition. But here's the thing. They don't need to sit in the waiting room in their uniforms or whatever. They can go back to their work area if they're not an acuity 1 or 2, and you can say that you can phone them when it's their turn. And I think that deals with the logistics of hospital staff. Again, they're all entitled to their privacy and dignity and confidentiality. And just because they're your mate or because they work upstairs on one of the wards doesn't mean that everybody needs to know they're there. So just a bit of thought on how that works, and maybe quietly moving them out of a back door back to their work area until it's their turn. Now, Judith's going to come in on this one with me because we've gone through all of that We've done 4 lectures now. Um, and those of you who are thinking about how am I going to manage this process, how am I going to do it, may have thought, I hope you've thought, how can I make sure that a member of staff is capable of this and um, is going to make consistently good clinical decisions about it? So we have written some mini KEXs. That's the shorthand for mini clinical evaluation exercise. And here's the explanation of what that is. It is an observed real life interaction between a healthcare professional and a patient, i.e., you're going to need to sit in and assess somebody doing this and as they learn it. Where the mini KEX assesses clinical skills, attitude, and behaviours, and allows feedback on performance from an experienced clinician. So get the hint, the experienced clinician is the one doing the assessment about a real patient in real time, and it gives valuable information to the clinical supervisor when completing assessment of capability. So what does all of that mean? It means that this is per patient, a mini KEX is per patient to see if people can do that per patient. And when they've got several patients and several good mini KEXs, which show that they're progressing and they're consistently getting better scores, then you will know that you're progressing to the point where you could let them fly solo. Now, how did we come up with them? Well, the Faculty of Emergency Nursing is very lucky to have access to emergency nurse experts across the UK. And so we sat down and we wrote them between us, and they got circulated round and round and round and refined as we went and tested. So that means that the mini KEXs we have written for primary assessment and for secondary assessment have been quality assured. They're free to download and print from our website under the documents heading, and you can do that, and then you've got an assessment tool that you can use to assess others. And we've also recorded some webinars on the use of those tools for people who will be doing those assessments, so that you can understand what that involves. And Judith, just talk us through a few of the things that came up
Okay.
as you were talking about how to assess.
Yeah. Can we go back a step before that
Of course we can.
to say that one of the reasons the Acuity project came about was because there were several different types of or methods for doing triage in the departments. And what we couldn't measure was like for like. So there was no standardized acuity measure between departments, and also between practitioners in departments. So I think having some sound tools are absolutely essential for us to be able to standardize the acuity, which was the main aim of this. So regardless of whether you're in Gloucester, Jeanette, where you are, or you're in Norfolk and Norwich or Cardiff, then if you're using the same tool, you should be able to assess to the same standard, and you should end up being able to not only assess an individual, because these forms have marking criteria as well that we've designed with them, which tell you when somebody's achieved or not, and that's part of the video as we're talking through it. But also it allows you to be able to assess between your nurses in your department, so you know they're all being assessed to the same standard. And if you think that we take it now wider and it's going to different departments across England firstly, and then we'll probably pick up in the other countries in the UK and possibly go into Ireland, then having something that we're all using standardizes it. And just to plea that all the the different assessment tools that we have developed have all been written in the same way, and that they are available for download, and we do not keep them behind a paywall, because we know how important it is that we're all doing things that are standardized, so we can measure like for like. And I know that having been part of the weekly meetings from the sites who have been the pilot sites and the early adopters, one of the things that they're asking about is how do we standardize to make sure that one practitioner is doing the same as another one within our department. And I think it's these mini kexes and the ESLIs will help us to do that. And as long as we all use the same measures to assess, then I think we will get there. And it's absolutely key.
Thank you. And you mentioned ESLIs there. So everyone's now thinking,
Yeah.
what's an ESLI? So let's move on to ESLIs. So ESLI is the acronym for an Extended Supervisory Learning Event. And here's the blurb on that. It is, it allows a supervisor to record observed practice, i.e. you're sitting in the room watching them, in the emergency care setting across a number of cases. It focuses mainly on non-technical skills. So for those of you in the know, that's the stuff that is talked about in human factors training. Although naturally, the clinical context is important, and decision making, of course, will be dependent on the clinical case. The ESLI is designed to take up to 3 hours in total. So that would be 2 hours of sitting observing someone either doing primary assessment or secondary assessment, or just sitting there for 2 hours marking them and watching each case going through and seeing that they consistently apply the acuity tool and consistently adhere to the standard set. And then up to an hour of feedback after the event to go through. Now, again, we've drawn up the ESLIs the same way. Again, they're free to download. And again, we have some webinars. And Judith, what was the things that you really wanted to draw out about the ESLIs particularly?
I think you've already said it really. It's about making sure that that practitioner is consistent over a number of patients. Because I can remember going back to a very early meeting we had with, well, how many assessments do we need to do on somebody to be able to sign them off? But I think if you have a mix of mini kexes where we're looking at the individual consultations with the patient, plus you're looking at an ESLI, so you're looking at how that individual performs over a period of time, then I think you've got the best of both worlds, and it triangulates what you're looking at and how you're assessing the individual. And I think the tools mean that when individuals are being assessed, that they know that it's standardized, that they're not being picked on. And I also think for individuals who've undertaken some of our mini kexes and other things, they have had such benefit from having constructive feedback on being assessed, that it's something we forget. And I think it's something as a practitioner we probably all crave, especially when we get in good feedback, because otherwise you tend to get just the negative, what you've done wrong, and it's not identified just how much you've done right. And I think that's another benefit of both the ESLI and the mini kex. But it will also identify what areas you need to consider for improvement,
Mm.
so that you've got an idea of what to put in your learning plans.
Mm. Thank you. So I've been out and I've done some field testing with these tools. And let me say up front, no surprises. Tell the person you're assessing what tool you're going to use and let them see the tool. And then carry on and do the assessment. And what's nice is seeing that they're good at some stuff and less good at other stuff. And as you go through, being able to show the person you're assessing you thought you're doing that, but consistently you're missing that step. Or look, actually, you get all of this bang on. It's this stuff is all really, really good. Um,
Mm.
it's just that bit and that bit that are slightly weaker. So a little bit more work, and you'll be consistently across the patch. And what's the advantage of that for the organisation? She says, tying it back to the risk register. I assure you, your chief executive wants some assurance that the risks are being identified and mitigated, and that he or she isn't up against a massive, massive problem. Many of them are at the moment. So being able to show them that the nursing staff who are being asked to deal with the highest risk in the whole organisation, and remember that, the nursing staff placed against the highest risk in the organisation are highly competent and can deliver consistently high quality. I would suggest you don't leave anyone in primary or secondary assessment for vast hours at a time. 3 or 4 hours is probably enough, and then rotate out. But just please remember
Mm.
that showing or you don't have to show your chief executive. He's generally busy people, but if they ask for the assurance to be able to say, here's our assessment tools, they're nationally agreed, nationally written, nationally agreed assessment tools. This is showing you that consistently I've applied this process, is gold dust, because that will enable that risk to be reduced. I think, Judith, that we just need to suggest that people may also be interested in
Mm.
um, our redirection lectures. So we will be doing some lectures on redirection, how you make those decisions, and getting that clinically correct. And again, addressing that risk consistently. You may be interested in our leading emergency nursing program. For those of you who are in team leadership level positions. For those of you who are in higher level positions, you may be interested in our fellow program. That's for those of you who are working as consultant nurses or matrons or practice development or lead educator roles. So that might be of interest to you. At the end of the video, you will find a QR code pops up. I'll shut up and a QR code will come up. If you zap the QR code, an evaluation form will come up. Of course, I'd like you to evaluate our performance on the lecture, but actually far more importantly, that evaluation form will ask you what you've learned, what you've picked up, what you can apply to your practice. When you submit it, it comes back into your own inbox in about 10 minutes, and then you can put it straight into your electronic portfolio, print it out to demonstrate to your manager you've attended the lecture, whatever suits you, and for whatever purpose you need it, or just into your revalidation portfolio if that's important to you, or maybe alongside a selection of mini KEXs and ESLIs that shows you've attended the lectures, so you've had the knowledge input, and then you've reflected on that, and then you've gone and done your assessments. So ready for the QR code, and thank you very much
Can I come
indeed.
in there for 2 secs? The other thing I think is important to say is that the lectures in the clinical program also go through what the red flags are. So they will take a topic and they'll cover the anatomy and physiology and go into a great amount of detail. Now, you may not think that you need it for the level that you're at, but they're always good for a refresher. And the other thing that we do have that are open to all is 17 at the moment sessions or lectures on how to assess. So there's a lot more out there on the faculty site that you can access and can use that will help turn you into a fabulous practitioner.
Thank you very much, Judith. QR code coming up now. Thanks for your attention.